we are online and live now. So hello everyone. Excited to see that we have so many registrations and attendees for today's session. So my name is Maximilian Mair. I'm a resident in medical oncology at the Medical University of Vienna, and it's my great pleasure to welcome all of you to today's session of the EANO Youngsters Journal Club on CAR T-cells in glioma. So before we dive into the data, I'd just like to give a very brief overview on the EANO Youngsters Journal Club format. So we aim to provide a 1-hour webinar discussing cutting-edge research following an interdisciplinary approach. We want to stimulate lively discussions and also networking opportunities in a friendly atmosphere. So who are we? We are a group of some enthusiastic neuro-oncology, young neuro-oncology professionals coming from diverse specialties and also countries. And if you are interested to join and to contribute, just drop me an email or contact me via social media. I'd also like to highlight the upcoming EANO meeting in Glasgow. So it's just 2 weeks from now. We compiled an interesting EANO Youngsters program, including mentoring sessions, pro-con discussions, and of course the EANO Youngsters Networking Night, which takes place on Friday evening. It's already sold out, so I imagine that many of you will have registered, and I'm looking forward to seeing you there. Last but not least, some information about the EANO Research Grant. Applications open today. So the grant aims to fund high-quality collaborative research projects led by EANO members. It's 50,000 euros. The deadline is in January, so consider to apply with your funding and project idea. Just last but not least, some housekeeping rules. You will find a Q&A function in your Zoom. Please use the Q&A to put in your questions and not the chat, because we're not monitoring the chat in the session. So please put them in the Q&A. Just type them in and don't forget to click on send, and we'll take them and discuss them afterwards. So today we'd like to discuss 2 papers actually published as short reports on local CAR T-cell treatment in glioma. So it's my great pleasure to welcome Stephen Bagley, who is an assistant professor and section chief in neuro-oncology at Penn Medicine in Philadelphia in the US. He is the first author of one of the papers we will discuss today. Then Joachim Steinbach, who is a neurologist and head of the Senckenberg Institute of Neuro-Oncology at the University of Frankfurt in Germany, who was also involved in clinical trials on CAR natural killer cells in glioma. Then Agnese Losurdo, who is a young medical neuro-oncologist based at Humanitas Cancer Center in Milan, also focusing in her research on cancer immunology in brain tumors and brain metastases. Then Sara Labiano, who is a postdoc at the Department of Pediatrics at the University of Navarra. Her research activities also lie in the field of cancer immunotherapy for pediatric brain tumors. So thank you all for participating. Looking forward to your insights in discussing our papers. So I will be the presenter, so I'll guide you through the results of those papers. But before we actually do that, I'd like to briefly set the stage for what we will be discussing. So we all agree that recurrent glioblastoma is still an unmet need, and we urgently need new and innovative treatment options. CAR T-cells are successful in many hematologic neoplasms, lymphomas, myeloma, also approved in these indications. And of course, there are also studies ongoing in solid tumors, but the efficacy is still limited or unclear there. There are many reasons for that. One of that is limited trafficking and persistence, so overall a lower number of functional CAR T-cells in the tumor, and also tumor heterogeneity in antigen expression and antigen loss over time. For those of you who might not be as familiar with CAR T-cells, just an introduction on how this concept works. So in a nutshell, CAR T-cells are genetically engineered T-cells that are re-engineered to detect a given cancer antigen and then elicit an anti-tumoral immune response. This is done by a so-called chimeric antigen receptor, CAR, which has a cellular stimulatory domain and an antigen recognizing domain on the surface. So when the antigen binds, co-stimulatory signaling pathways are activated and antitumor immunity is then elicited. How does it work in clinical practice? So T cells are extracted from the patient. This is a process called leukapheresis. CAR T cells are produced in the lab. So a gene for this chimeric antigen receptor is inserted to the T cell, mainly via viral transduction. Then the T cell expresses this CAR protein. Millions of those CAR T cells are cultivated and grown and then infused into the patient. Those CAR T cells then bind to cancer cells and are able to kill them. However, this abundant release of pro-inflammatory cytokines also has a downside. They exert their action also on systemic level. This is what we call cytokine release syndrome, including fevers, low blood pressure, hypoxia, and so on. Those cytokines also in turn lead to an increased permeability of blood vessels, which leads then to a disruption of the blood-brain barrier, with cytokines that are then also acting in the brain and in the central nervous system, and causing adverse events there. This is what we call ICANS, immune effector cell-associated neurotoxicity syndrome. One might speculate that an application of CAR T cells in brain tumor might lead to a higher probability of such side effects, but that will be something we will discussing later on. So this year, actually 3 major papers on CAR T cells in glioma were published in a month or so with different CAR T cell products that I will outline them down the road. So the first one is already Stephen's paper published in Nature Medicine, a renowned journal with an impact factor of 58.7. We know the first author as he is a discussant today. The last author is Donald O'Rourke, who is a neurosurgeon at Penn Medicine. So what is the investigated product? The authors developed and evaluated a dual IL-13R alpha-2 and EGFR CAR T cell product, so a CAR T cell binding to 2 antigens by a bivalent CAR T cell product. The idea behind that is that you can improve efficacy and overcome tumor heterogeneity by targeting 2 antigens. So those IL-13R alpha-2 antigens, which are tumor-associated antigens, and wild-type EGFR, but on this epitope, and the authors argue that the antibody is not binding to physiological EGFR, causing less on-target of tumor toxicity, which is frequently a concern in CAR T cell treatment. So the authors performed a single-center, open-label phase 1 trial. Key eligibility criteria were recurrence of IDH wild-type glioblastoma after prior radiotherapy, EGFR amplification detected by FISH. Exclusion criteria were no bevacizumab treatment less than 3 months before inclusion, and no brainstem or spinal cord location. So it is a phase 1 trial, so the primary objective is safety with dose-limiting toxicities, maximum tolerated dose, and adverse events as primary endpoints. Then there were secondary objectives such as feasibility with number of patients on treatment and manufacturing failures as secondary endpoints, and efficacy, here progression-free survival as evaluated by modified random criteria was chosen as secondary endpoint, along with objective response rate, duration of response, and overall survival. In this figure, you can appreciate the overall study flow. So apheresis was done minimum 1 late after completion of first-line treatment. T cells were collected, then at recurrence had to be histologically verified. Patient was then enrolled. T cells were manufactured, and in surgical resection, the patient also received an Mair reservoir, and there those T cells were then administered locally. So there were actually 3 dose levels according to the protocol. In this paper, however, only cohort 1 and cohort 2, so the lower 2 doses were reported. CAR T cells were then injected, and an MRI was done 1 to 2 days after administration and then monthly thereafter. So how were safety evaluations done? There is a grading framework proposed by the American Society for Transplantation and Cellular Therapy for cytokine release syndrome and also ICANS. So cytokine release syndrome, including ICU admission, hypoxia, low blood pressure, and fevers, and ICANS, including seizures, status of alertness, cerebral edema, and so on. However, this is challenging in brain tumors, as these are symptoms that are also happening just related to the tumor. That was the reason that the authors amended this framework and introduced baseline as a time point for comparison. So you see that there is a lot of points below baseline, worsening, and also symptoms that are attributable to the location of the patient's tumor are included here. So let's start with patients' characteristics. Typically glioblastoma cohort, so 6 patients. There were no female patients, but most were MGMT promoter unmethylated, just as we know it from clinical routine. Most patients were between the first or the third relapse. Also, previous treatments were pretty standard, including radiotherapy, temozolomide, lomustine at recurrence, and so on. The number of months from the last radiotherapy, also as we know it from clinical routine with patients with MGMT promoter methylated tumors, having longer time to relapse than those with unmethylated tumors. The authors also showed pre-treatment immunofluorescence staining, so TAPI, which just shows nuclei, EGFR, and IL-13R alpha-2, which are the 2 targets. Interestingly, IL-13R alpha-2 was not included as an inclusion criterion, as the authors argued that there was no validated assay and no clear cutoff to validate that. Still, you can appreciate here in those immunofluorescence images that there is some heterogeneity in target expression, and that target expression is overall somehow lower for IL-13R alpha-2 compared to EGFR. Just a very brief glimpse on safety data. So there were no grade 4 and grade 5 adverse events, still some grade 3 ones. These included actually decreased lymphocyte counts, skin ulcerations, fatigue, and anorexia in 1 patient who was treated with higher dose. That was actually a dose-limiting toxicity. Of special interest are neurotoxicity and cytokine release syndrome safety data. But for neurotoxicity, no difference between 2 dose levels. CRS was somehow more severe in the higher dose. So neurotoxicity was then treated with dexamethasone in all patients. 5 patients received anakinra, an interleukin inhibitor, or tocilizumab in 1 patient, and then bevacizumab in 1 patient, but that was against tumor-related edema then later. So then some overall remarks on efficacy. So the good news, reduction in size was observed in all patients on the first MRI 1 to 2 days after administration, but none met the criteria for objective response per modified RANO criteria. Let's go briefly through some included MRI images. So this is patient 1 who was treated at a lower dose level. You can appreciate here this tumor nodule in the left occipital lobe, which nearly vanished 1 day after CAR T-cell treatment, was then again appreciable 1 month after CAR T-cell treatment, but it already suggests some central necrosis here. So still some response, also if you compare it to the day 1 before CAR T-cell treatment. Then also surrounding the resection cavity, there was tumor progression before treatment. Also here, less contrast enhancement on day 1 after CAR T-cell treatment. Then there was progression. Here actually a resection or biopsy was taken, which has shown treatment-related changes actually. The patient was then progressive 2 months after CAR T-cell treatment. Unfortunately, we don't have images on that, but was still alive at the time of the report. In patient 2, a large mass in the right temporal lobe decreased after treatment, but then showed growth until 1 month afterwards, but actually then remained more or less stable, as it is described in the paper. So overall, a bit of waxing and waning pattern we can observe here. The patient, however, developed communicating hydrocephalus after the 2-month scan, declined an intervention, and then ultimately deceased. Patient 3 had a nodule in the right temporal lobe. What is interesting here in the lower panel is that you can see some sulcur enhancement, which might suggest leptomeningeal involvement of the disease, which, however, disappeared after CAR T-cell treatment and was also stable in 4 months after CAR T-cell treatment. And overall, the patient remained stable until the time of the report, so 4 months after CAR T-cell treatment. So let's go to dose level 2. Here, patient 4 had multiple nodules pre-CAR T-cell treatment, which all demonstrated reduction then. And what is interesting here is that dexamethasone treatment took place after the first scan. So here you can't argue that maybe the MRI image just shows response related to dexamethasone or some kind of adverse event treatment. And also here the patient remained stable until 3 months after CAR T-cell treatment. So patient 5, also substantial reduction of this relatively large tumor bulk here. However, already 14 days after CAR T-cell treatment, MRI image showed a worsening situation actually, which was paralleled by a tapering of corticosteroids. So then the patient was again put on dexamethasone, and the 1 month image showed a response. So the author argued that actually what we see here on the day 14 scan is pseudoprogression. And here also the patient remained stable at time of the report, but there was no 2-month scan then in the paper. Also in patient 6, marked tumor progression before CAR T-cell treatment, but afterwards decreased contrast media enhancement. This patient actually received a single dose of bevacizumab due to worsening weakness on his right-hand side, but then remained stable. In the end, the authors showed some exploratory data on pharmacokinetics. So they collected blood and CSF. So these are qPCR results of the CAR gene in the CSF. So you can see that those increase markedly until 1 to 7 days, remain relatively stable, then until 28 days. What is very interesting here is that the CAR gene was also measurable in the blood, suggesting that there is some communication between the CSF and blood compartments. This is now just single patient level data for CAR T-cell persistence in the CSF. And here, same, but just with milliliters CSF as reference and not with gram of genomic DNA to account for differing cell counts. Here, and that's a very interesting point in my opinion, some cytokine analysis data where I can see that interferon gamma, interleukin 2, TNF alpha, and EL6 all decrease until 1 day, but then return to baseline starting from 1 week after treatment then. So in conclusion, administration of CAR T, EGFR, IL-13 or alpha-2 cells was overall safe and suggested preliminary efficacy signals. Exploratory analyses indicate persistence and engraftment of those cells, which are also paralleled by immune activation. Of course, it's just a phase 1 trial, so we need further confirmation of efficacy signals then. I just check whether we have any pressing questions. Yes, we have one question actually. Did patient 4 receive anakinra before the first MRI after CAR T-cell therapy, which also might reduce contrast enhancement? I think I'll give this question to you, Stephen.
Yes, it's an excellent question. This patient did not receive anakinra before that MRI scan. They received both steroids and anakinra after that scan. Same thing with patient 5, which was the other fairly remarkable initial regression. That patient, all of the radiographic improvement occurred prior to any dexamethasone or anakinra. So we may talk a little bit later about whether there could be some anti-angiogenic effect of the cytokine release that's happening and whether that is contributing to some of these rapid, regressions. But I cannot blame them all on steroids or anti-cytokine treatments.
Okay, yeah, definitely interesting point also to put up then for discussion afterwards. So thank you very much. There are no further questions right now, so I think I would just go on to the second paper as there are some common themes that we will then discuss in the end. So, second CAR T-cell approach, an EGFR variant 3 CAR T-cell with a secreted T-cell engager. So this paper was published as brief report in the New England Journal of Medicine, a journal we all know very well with an impact factor of impressive 96. So the first author is Brian Choi, who is an assistant professor and neurosurgeon at Massachusetts General Hospital. Last author is Marcella Maus, who is director of the cellular immunotherapy program at Mass General Cancer Center. So what is the investigated product here? So this CAR T-cell platform combines a conventional CAR T-cell targeted at EGFR variant 3, which is frequently expressed in glioblastoma samples, with a bispecific T-cell engaging molecule targeting wild-type EGFR. So by that, CAR T-cells, but also other T-cells, such as also regulatory T-cells, can be activated within the tumor and elicit an anti-tumoral response. So also here, the authors performed a single-center, open-label, non-randomized phase 1 trial in patients with IDH wild-type glioblastoma at confirmed recurrence after prior radiotherapy. EGFR V3 expression as detected by sequencing. Measurable disease was a requirement, so at least one lesion with at least 10 millimeters of diameter, and no prior EGFR V3 targeted treatment was allowed. The publication here reports the data of the safety run-in cohort, which is 3 patients. So what was the study flow here? Patients provided consent, leukapheresis was performed, T-cells were manufactured, patients received then surgery for Mair reservoir placement and tissue sampling, T-cells were then administered, and patients had regular MRI scans later on. There was a bit of different timeline for participate 1, as here resection and Mair reservoir placement did not take place in one surgery. That was something that the authors then amended to their study protocol, and participant 1 received a second infusion in a compassionate use-like setting after approval from regulatory authorities. So this is just patients' characteristics, which are also rather standard for glioblastoma cohort in terms of demographics and prior treatment. What is interesting again is safety. So there were 2 grade 3 events possibly linked to the investigational product, which included encephalopathy and fatigue. Interestingly, 2 of those patients had cyclic fevers and pulmonary nodules. They were transient. It is hard to speculate what the reason is. Is it systemic inflammation due to CAR T-cell treatment? Is it maybe even an anti-EGFR toxicity issue? We don't know. But actually, systemic inflammation will be more probable as the CAR T-cell was aimed specifically as EGFR variant 3. So these are just some images on patient 1 who had a recurrence 1 year after diagnosis. And you can see here at the before and after scan, the contrast enhancement showed a marked decrease. As I said already, a second dose was administered after approval of regulatory authorities, but the patient ultimately had progressive disease 2 months after the discontinuation of the study project, which was, however, due to GI perforation after bevacizumab treatment, so not related to the study compound. Here, the authors show result of a liquid biopsy approach. So they measured extracellular vesicle RNA for EGFR-V3 and EGFR in the CSF, showing an increase first and then a decrease to levels below the detection threshold. They also did that in blood, where they could also confirm this marked decrease. Although in blood copies are very limited, but that is something that we would also expect. Participants 2 and 3 also experienced progression 20 and 12 months after initial diagnosis and initial first-line treatment. Participant 2 had an impressive response, which was also durable, so more than 150 days, which is 5 months. Also here you can see a decrease of EGFR-V3 and EGFR extracellular vesicle RNA. Patient 3, also some decrease of contrast enhancement after infusion. Of course, it's always hard to speculate what is actually going on here, as you can just appreciate less contrast enhancement, and we don't really know what's going on in the tumor biologically, but there is an appreciable response according to MRI, but this patient had progression 1 month after infusion. Interestingly, patient 3 was negative for EGFR-V3 at recurrence, at least according to histology. If you're looking to the supplementary figures, however, you can see that extracellular vesicle RNA was detectable in the CSF. So maybe it was just a sampling error or just a methodological issue with the re-resected tumor, as these results suggest that there was still EGFR-V3 present in the tumor. Also here again, the authors show some correlative data, body temperature course after CAR T-cell treatment, showing these cyclic fevers, which were treated with anakinra in these patients. This shows flow cytometry data. So actually this CAR T-cell project had a third transgene for truncated CD19, which was used as a marker for CAR T-cells, also in flow cytometry analysis. And here you can see then actually the gating strategy between CAR positive and those T-cell engaging molecule positive cells, and others that were respectively negative then. This shows quantification of CAR positive and heme positive T cells. So actually a vector copy number analysis that was done here, and then some flow cytometry data. And then again, where you can see that also those cells seem to persist intrathecally. Again, some cytokine data where you can see an increase of cytokines in the first week after treatment, as we had it in the paper before. And also here, very interesting that also vector copies and cells were observable also on systemic level in the blood. So also here in conclusion, administration of this CAR T-cell product is overall safe and suggests preliminary efficacy, even in non-EGFR-V3 individuals, as the authors argue, although we don't really know whether the whole tumor was EGFR-V3 negative actually. And also here it's a phase 1 trial, so further confirmation is needed. Just very briefly, one last product that has been investigated, IL-13 alpha-2 CAR T cells itself, was published in another great Nature Medicine paper this year, also local regional treatment. actually more patients that were included, but also more arms with different CAR T cell products, one with memory-enriched CAR T cells showing somehow better outcomes clinically, but also then in translational analysis where you can see more cytokine release and more immune activation. So in comparison, we had actually 3 different CAR T cell products. One a bivalent CAR T cell, one a CAR T cell secreting T cell engagers, and one that was memory enriched with different targets, but all administered loco-regionally. All were single center non-randomized phase 1 trials in rather small cohorts, at least so far. This one was in a larger cohort, but again, different arms and different products that were used. One dose-limiting toxicity in the first paper we have seen. All described responses, although response assessment is an issue because modified RANO criteria are, of course, not based on evidence generated for the evaluation of immunotherapeutic agents, including CAR T cells. So this is definitely something we can discuss right now. So of course, it's all interesting phase 1 data and interesting proof of principle data. None of those studies was, of course, designed to prove efficacy. These are rather low N with limited follow-up times. And the question remains on how we prove efficacy and how we perform response assessment in those patients and what those radiological changes exactly mean, actually. So with that, I'm at the end of my presentation, and I'd like now to open the discussion. So for first, I'll just have a look on whether we have any questions. Please don't be shy. Put in your questions to the Q&A tool, and we'll take them up and discuss them. I have actually one question. What could be the reason for the initial increase in EGFR V3 copy numbers after infusion of CAR V3 team E T cells? This was related to the second paper we have discussed. Actually, we don't really know. It wasn't discussed in the paper. Could be just tumor cell lysis, we don't know actually, but that's not something that has been discussed in the paper. And that's actually also something that just took place in this first patient that they shown, because the second one, I've shown those data, just showed a decrease then. But actually, that's not something we, it's just something we can speculate about. Then I have one question again. The decrease in contrast agent uptake intensity a few days after administration of CAR T cells without a visible mass effect could also be due to changes in the permeability of the blood-brain barrier. Standard imaging does not seem to be sufficient. Is there advanced imaging before and after these CAR T cell therapies? Stephen, do you have any insights on that?
Yes, and again, it's in line with the previous question about, you know, what else beyond an actual anti-tumor effect may be contributing to some of these rapid decreases in contrast enhancement that we're seeing across both our study and the MGH study. I think that to directly answer the question, yes, at least in our study, I can't speak for MGH, but we do advanced imaging. We do, you know, basically relative cerebral blood volume and plasma volume quantification. And we do see, not in every patient, but in some patients, a reduction in those metrics at those very early time points. I don't know what that means either, though. That could also potentially be an effect of all of this inflammatory cytokine storm that's occurring in the CNS in these early days. So the bigger picture answer to the question is, I personally don't put a whole lot of stock into these early radiographic responses as being anything other than signs of bioactivity, that there is some biological effect being exerted by these cells because we're seeing it in the absence of steroids and anakinra and other things which are administered later. Now, whether that bioactivity is only a modulation of the blood-brain barrier in some way versus real anti-tumor effect, that is what we're going to know with time. how many responses become durable? How does the progression-free survival look? And ultimately, as we're going to talk about designing the next generation of studies here, are they going to be randomized? If so, what's the control? So lots of important questions there.
Yeah, thanks a lot for those insights. Actually, regarding response assessment, there was one question before that was answered then via the in written. Pierre Meneret asked, "Did you monitor the disease by amino acid PET?" Maybe Stephen, if you could just give some very brief or remarks on that also.
Yes. So at present, we have not done amino acid PET in any of the patients treated so far. We are amending our protocol to add fluciclovine PET scans in the future. It's very difficult in the United States actually to get access to amino acid PET imaging. The only FDA approved tracers we have are for prostate cancer with fluciclovine, and we're going to have expanded access to FET PET pretty soon through Telix, but right now we don't really have it. Like, I can't just order it on my patients. It's only available in research protocols, and as you know, it's expensive. So asking the funding sponsor to add it to our current trial is a big ask.
Okay, great. Thank you. Then, maybe that's a question that also others, as all of you are working in immunotherapy of gliomas, can give some insights about. Antonio wrote, here we have seen various cases where treatments have been favorable, but how do you view the immunosuppressive role of the tumor microenvironment in limiting the efficacy of current immunotherapies? So I'm just asking.
Maybe this is something I can comment on, because we are addressing this also in our trial, and to stretch out a little bit for the audience. I mean, it's great to have these trials out there, because now I think there are two major changes to the CAR T-cell field for glioblastoma. One is that all now embrace the local regional application, so via Mair reservoir into the CSF. And I think this is a departure from blood, because we know that from the blood, we just don't have enough transmigration into the tumor. There are some other ideas like opening up the blood-brain barrier with focused ultrasound, and I think that's interesting, but still experimental, because ultimately, of course, if you see the future in 10 years, we certainly would prefer to have systemic application. But for the time being, I think it's clear that almost all trials are now going for intraventricular injection. We have made the experience with the CAR-NK cell trial where we started to put the CAR-NK cells into the resection cavity. And those were pretty small volumes in some patients, and that caused problems. And so we are also switching now to intraventricular route and have seen promising results. The second major achievement, I think, of these trials is that now the first generation of combination CAR-T agents is out, so either with TEAM or with a combination of two cognate antigens, and that's an improvement. We'll see how many antigens we need. Ultimately, this is you're chasing an elusive target here, and again, the microenvironment, heterogeneity, and tumor evolution are all important. One thing that we think is really important is the question whether we can initiate an endogenous immune response if we have a sufficient degree of immunogenic cell death. And we may have then antigen spreading or more epitopes that are available to circulating immune cells. And that comes back to the question, what is actually going on with the immune suppressive tumor microenvironment? Because in order to engender an endogenous immune response, which will maybe ultimately solve our problems with tumor evolution and antigen escape to pre-specified receptors, we have to tackle this. One obviously really cheap answer is what we did in the CAR-T-brain check trial, is just adding an anti-PD-1 antibody. But we did this because the preclinical trials really showed that in response to CAR-NK cell attack, the tumor cells upregulate PD-L1, and this really suppresses the endogenous immune response. But now we have much more agents for combination therapy in the toolbox out there, and it will be interesting to see in the next generation of clinical trials what makes sense. So the team actually has an inbuilt combination partner, but we'll see more of those. I would like to see more, individualized combination approaches where you profile the tumor from the biopsy or resection, or even maybe if we advance the technique by a liquid biopsy, and then design a rational combination immunotherapy, put this into the patient, then let this run, and then at progression, again, do what they also call now reverse translation, and see whether we can, again, put it on track. And I think those are some of the ideas how to tackle this, which will keep us pretty busy, I guess, in the next decade or so. I don't know what the other discussants say, or whether you agree, or whether you have any specific interesting strategies there to add to this.
So yeah, I completely agree. I mean, we really need to think about the tumor microenvironment in terms of tumor immune microenvironment. I'm not very close to the glioblastoma, but in pediatric tumors like diffuse midline glioma, for example, there is no T cells inside. So if you think about the strategies, these team strategies, I mean, having an engager maybe is not the best way to go unless you inflame the tumor before with endogenous T cell compartment. So yeah, I completely agree that, I mean, thinking in a personalized way, it will be the best for the CAR T cells.
Yes, also I can comment that also for the persistence of the immune response at the tumor site, maintaining an inflamed tumor microenvironment, it would be crucial to also maintain the cytotoxic effect of the T cells that we put in, and we try to activate against the tumor antigens. So the crucial point would be how to maintain the tumor microenvironment inflamed and maintain the persistence of cytotoxicity of these T cells that we infuse to attack tumors antigens.
Actually, I have a very good question from the audience, which is also related to persistence of CAR T cells. Is it understood, or can it be estimated, for example, from the qPCR data, what percentage of cells stay around the tumor or in the brain, and how many migrate to peripheral tissues instead? Does any one of you have insights on that?
So I can comment a little bit on what we've seen in our study so far. So the perfect way to start to get at this question would be to sample the tumor tissue, very soon after the CAR T cells go in. And we've actually had a very hard time doing that in our cohort so far, mainly because the patients are getting quite sick with neurotoxicity, and we're seeing the tumors regress early on. So we haven't had a clinical opportunity in many of them to kind of go back in those early weeks, which is something we had done a lot in our previous studies because tumors were growing very quickly. And so we went back in and it was clinically indicated. And so we were getting, tissue to look at to understand what were the immediate effects on the tumor and microenvironment. We haven't been able to do that as much in the current study. And so we're really relying on the CSF and blood correlative studies. And what we generally see, and Max showed some of this before, is the CSF persistence, at least by qPCR, is out to day 28 in every patient. But in some of the patients who are longer-term responders, and for example, the third patient treated that Max showed, the one who was 4 months out at the time of the publication, is actually now 14 months out with continued stable disease. So he's been one of our patients who's been a bona fide long-term responder to this treatment. And what we see in him is that we're still finding the CAR T cells by PCR in the CSF and blood at 14 months. So they're still detectable. So this is a case where the persistence seems to correlate with with the response. In many of the patients who've relapsed in those early months, we lose signal both in blood and CSF around that 28-day mark. So I think there is some clear correlation between persistence and efficacy. But what's happening when they get to the peripheral blood, I really don't know. You saw the graphs, all these patients become detectable in the peripheral blood between 7 to 14 days. And we see that higher blood detection tends to translate to more cytokine release syndrome. So it kind of makes sense, more systemic exposure. But whether that translates into any benefit in terms of efficacy is yet to be determined.
Thank you very much. Actually, I have another question here right now. Would it be possible to comment on whether the peritumoral edema and the worsening of existing neurological symptoms that was labeled as ICANS may be a more localized tumor inflammation-associated neurotoxicity instead? Maybe, Stephen, if you want to take the question, as I know that that was also discussed in the paper. I just didn't bring it up before.
Yes, so I think the question, if I understood it correctly, is really getting at this concept of more global inflammatory encephalopathy, which we refer to as ICANS, versus a more local peritumoral inflammation phenomenon, which is published as TIAN, or tumor inflammation associated neurotoxicity. Which is really just like it sounds like. You're getting peritumoral edema, inflammation, and then depending on the location of the brain, you might see downstream symptoms and potentially even elevated ICP and herniation in the worst cases. We really see much less of that with our product and much more of an ICANS-like picture. It's more of a global encephalopathy. But we do see a little bit of TIAN as well. One of the patients who's the best example is not in the paper. He was treated in the next cohort, had a large splenium of the corpus callosum, butterfly glioblastoma. And when that, about 3-4 days after the treatment started to get some inflammation around it, he developed hydrocephalus and needed an external ventricular drain emergently. So that was a case that would be graded actually as grade 4 TIAN according to the criteria, because it required intervention. So I think it's a spectrum, and it's not always black and white. I think there can be a little bit of both. Certainly interested if other panelists have thoughts on that question too.
Well, I can comment on this too. I think it's a very interesting question, absolutely, because like the two progressions that we see with immunotherapy of brain mets, this is something, I think there's a balance. We want to have some degree of immune activation. We don't want it to overshoot, and I think we need to develop those distinctions. Actually, with CAR NK cells, which generally produce much less ICANS, we nevertheless saw what you call TIANs, because just in those patients where the resection cavity was quite small, and we did repetitive injections, we had a lot of cytokines, and then we had peritumoral edema, seizures in some patients, but never a case with true ICANS. So that's another interesting, I think, topic. Maybe this is not a topic for today, but regarding the perspectives of cellular immunotherapies, it's also very important to think about the kind of product. Now, you had classical CAR T cells with the whole manufacturing process and a certain delay. There are other strategies out there to speed up the process. There are some strategies for off-the-shelf products. And then at one point, cost will also become an issue. It's already an issue when you start to finance your clinical trial, right? So this is already expensive with CAR T cell strategies and virus transduction and everything. So I think we need to find answers for that too.
Maybe I can comment another, I think indeed another important aspect regarding the antigen of the tumor. We all know that there is an heterogeneity in the tumor, right? But I would like to know your opinion about this, because at least in pediatrics, there are clinical trial testing 4 CAR T cells at the same time just to avoid this antigen loss. So what do you think? I mean, this is not leukemia, this is glioblastoma, central nervous system tumors. We do not have a common antigen to target. So how can we overcome this issue?
It's an excellent question. I wish I had a good answer. Not sure if anyone else has thoughts on that. This is a bit of a futuristic thing, but I think, you know, one of the ideas that's fairly easy to be interchangeable and to change targets quickly would be to use mRNA CARs, you know, where you could theoretically, you know, quickly develop a CAR for an individual patient against, you know, some antigen that is highly expressed at that moment in the patient's disease course, and you could theoretically switch that out for other antigens pretty easily as time goes on and they relapse, and those cells are not, you know, going to persist the way that a DNA CAR would, and so there's potentially less toxicity and things like that as well. But I don't know about a universal kind of approach here, so like an allogeneic approach for GBM. I don't have any good ideas there.
Well, maybe one, I understood your question is, so one is the technical aspect that Stephen addressed now. The other is really how to define your antigens, right? And I think maybe for the general audience, it's interesting that many of us are going now for not true private antigens, that is mutated exclusive antigens, but for embryonal antigens, and IL-13 and EGF receptor are two prime examples of that, because we just know that there are much less private antigens in brain tumors than we have previously thought, on much less certainly than in the hot tumors and the carcinogen-induced tumors like melanoma and lung cancer. But I think there's also a technical development. Many people are still relying on sequencing and on some algorithms that predict then the mutanome. And actually, it turns out, if you look closely, that by far not everything what we predict is really expressed on the cell surface. So I think it's also really important to map, and some people do this by immunopeptidome analysis, which is a lot of work. And I think so far this is not feasible to do this on individual patients. But I think this will help ultimately to define really credible targets for CAR T cells, right? So this is also perspective for development, I think.
I have one other question from the audience. Did you have the chance to check the CSF for the composition of other immune cells after CAR T cell application? And if the answer is yes, were there differences before and after application or differences between patients?
Yeah, so this is something that is still a work in progress, but there's some incredible single cell RNA sequencing data that one of our main collaborators at Penn, Dr. Dana Silverbush, has been working on. You know, one of the greatest things about having the Ommaya reservoir for treatment is that you can access it regularly for repeated, you know, CSF correlative studies, and it gives us a source of biomarker development that we don't typically have in glioblastoma. And so she's been able to get this really rich single cell sequencing data at every time point following treatment. And there are definitely, you know, differences emerging from patient to patient. There are very clear differences in responders versus non-responders. I won't give away too much of her data, but just one tidbit is that the super responder patient that I described has a very different profile in the first week compared to many of the other patients. You see a marked reduction in regulatory T cells actually in that patient, whereas in many of the early relapsers, you see an increase in regulatory T cell proliferation in the CSF in that first week. And so that, you know, Tregs may be a big part of the resistance story. But it's incredible how much you can get from these large volume repeat samples.
Maybe to take another question from the audience, is anyone of you aware of any CAR T cells that are studied in non-glioblastoma gliomas, so IDH mutant, lower grade gliomas? Sara, you were talking before about diffuse midline gliomas, although those
okay.
are mutant and so.
I thought the question was regarding low grade. But, not really for low grade from my side. But for pediatric high grade or these diffuse midline gliomas, yes, there are at least, well, quite a lot clinical trials, most of them phase 1 clinical trials, which they test some common antigens with the glioblastomas, for example, EGFR, and also interleukin-13 for receptor. But yeah, and also the thing is that they test them intraventricularly, same as Stephen and colleagues. I think, and maybe Joachim, you don't agree with me, but I think that's the way. I really like the intratumoral administration, because we are very aware about toxicity in the pediatric field. I mean, we want to cure them, right? We want them to have like a normal life in the future, and I think this is also important. So neurotoxicity, it's a big issue now, also for CAR T cells and other cell therapies. So no, for the answer is no. I'm not aware about low grade assays using CAR T cells. Sorry.
And maybe as you brought as you brought up another important thing on toxicity, is there actually any good comparative data comparing local treatment with systemic treatment in terms of toxicity? I mean, it's always difficult to do cross-trial comparisons, but still.
I mean, in the trials that we've done previously, that we did an EGFR V3 single target peripheral blood administration in recurrent GBM, and there was essentially zero toxicity, but I would argue there was probably also zero efficacy. And we did a follow-up study of the same product with pembrolizumab in combination, and we saw a little bit of pembrolizumab toxicity, but really nothing that could be attributed to the CAR T cells. And same thing, not a lot in the way of efficacy. So I think the theme across cellular therapy in general, and Joachim was talking about this earlier, we want some degree of toxicity as a metric that you're exerting bioactivity and having activation of the T cells, but there should be a sweet spot where we're not pushing patients over the edge. And I think that gets back to the low-grade glioma question. I think right now, giving our therapy, for example, to low-grade gliomas, the risk-benefit is very questionable. You're really putting people through a lot when the benefit is not proven enough yet for somebody who's got really other good treatment options in the low-grade setting. And by the time those patients are multiply relapsed and high-grade, they're already in a pretty bad situation where it's more like a glioblastoma. And there you could use them, but I'm not sure, at least with our product, that would be the right choice. So it's a challenging question, because I think you're right. We ultimately want to treat patients earlier in the disease course. And I think maybe even moving our current products into first-line GBM is something we're starting to think about, perhaps in the maintenance setting after radiotherapy would make sense.
And maybe, as we are already nearing the end of our 1-hour session, there was one question: how would you design a large clinical trial with intraventricular CAR T cells? So how would that work? Also in terms of a control cohort that you would use then? Maybe that's a good question for all of you.
Well,
I would like also to give me the answer on that.
Right, sorry, Stephen, go ahead. I was just saying, it starts with the definition of our treatment cohort. So if we find a strategy where we can do a molecular test and include a cohort of patients, if we start to have completely individualized treatment, then it gets very difficult to find a control group. So if you have like a 3-CAR, like Nabil Ahmed's group, or you think you have can have a good definition by a standard immunohistochemistry or FISH screening test, then I think it would be feasible, and you just take those patients, construct a control cohort, and expose them to lomustine, but what we always do, And then it's, of course, we need advanced imaging. We really need liquid biopsies and tissues and radiology. But I don't think why we cannot run this trial like any other trial of a treatment. We just need hard endpoints. Certainly OS would need to be an endpoint because with imaging, we're just so unsure. And I think it could be done. But again, the cost is really prohibitive for CAR T-cell strategies if you don't have a company who backs it and with the promise of putting a product into a market. So this is, at least in Europe, this is a problem where I wouldn't know how to run a randomized phase 2 trial or how to finance this. Again, some products that come off the shelf may be cheaper and this may be easier to do then, but it will be a challenge. Anyway, I don't know what about the US, Stephen. Are you really thinking about doing a randomized trial?
Yes, I think as you brought up, you're exactly right. The finances actually become one of the main issues. I think if I pretend for a moment that that's not a problem, we have unlimited money. I think that doing a randomized trial of these intraventricular CAR T cells and recurrent GBM is very difficult, very, very difficult. I am not sure. Obviously, you can't do this placebo controlled, right? It's going to be open label. And if you have lomustine, for example, bevacizumab, physician's choice chemotherapy, whatever it may be as the control arm, you're going to have attrition and dropout of patients. You can imagine if you have recurrent GBM and you're put on that study, you're not going to be very happy about getting lomustine and not the CAR T cells. And so I think that's always a problem in our field. I think, the other problem is that they take time. You have to leukapheresis the patient. You have to manufacture the product. And recurrent GBM is a disease where we can't wait too long. So I think for all these reasons, doing a newly diagnosed randomized study is a little bit easier. There are still some logistical hurdles, but I think I can envision, for example, an unmethylated, MGMT unmethylated patients, you could give standard of care radiotherapy, and as a maintenance therapy afterwards, you could potentially randomize to CAR T cells versus standard temozolomide. I think that's a study that would probably fly at most places, but there's still the financial part of it, which is a massive concern.
Maybe Sara and Agnese, do you have any wish list on translational endpoints to include in such a trial?
Yes, for sure. It would be really interesting to have tissues and CSF during parallel studies during all the ongoing treatment of the patients, both for the, let's say, standard treatment and the CAR T treatment that we propose as the interventional treatment, because we know, or we might easily know what's happening in the peripheral blood, but it's very difficult to understand what's happening in the tumor microenvironment live while we infuse CAR T cells, so how they engage with the other immune cells. That's also why it would be interesting to have, I can see in one of the questions that someone envisaged like organoids to study the use of CAR Ts and the new antigens on the GBM cells. This would be really interesting also because we know that antigen loss, antigen depletion, it would be also something happening on the way, on the history of the natural history of the disease, also during treatment. So it would be optimal to maybe get tissue, maybe build an organoid ongoing during study treatment, and in parallel study response to therapy live in the patient and in the lab, and then match and maybe study what's happening in the tumor microenvironment and also on the intersection with other immune cells, because we know, as we said before, that T cells are not the most represented population in glioblastoma, so maybe also macrophages, so mononuclear cells play an important role. Neutrophils, which are very difficult to study if we don't have it in a fresh specimen, have an important role, which we actually lack in studying in vivo. So yeah, that would be something that we can do in a trial, but very or impossible to do in the clinic. So yes, I would have an important translational part during such kind of trials.
Yeah, thanks for your take. Sara, do you have any last thing on your wish list for such a trial?
No, not really. I mean, I completely agree with all the discussants and with Agnese. I will, if I could have a sample of tumors upon treatment and study, I mean, them fresh tumors, that would be the best. But of course, I mean, we have to take care about the patients, right? And they are first in these things. So no, not really. I think it's very difficult this right now. But maybe any biomarkers in the CCF or in the blood would help. Yeah.
Okay, great. Thanks. I think that is a great last message to wrap up our session. We're already a bit over time, but it was an interesting discussion with all of you. So thanks again to all of you for participating. It was a pleasure having you here for today's Journal Club session. And also to you as participants and attendees, thanks for participating today. Actually, I have put a link to an evaluation form to the chat, so please answer it, but you will again also receive the link in an email together with a certificate of attendance for today's session. So thank you all very much and have a nice evening. Goodbye.
Thank you. Take care.
Thank you. Bye.